Hey guys, Miss Hill here, and this is a continuation of individual module 5.2, PowerPoint 1. So we're going to proceed with lecture 3 of this PowerPoint, and I apologize, it cut me off on lecture 2 because my computer didn't have enough space. So we're going to finish up talking about fetal responses to labor and birth and fetal heart rate interpretations. So let's talk about fetal responses to labor. Specifically, we're going to focus on heart rate, acid-base status, hemodynamic changes, and then fetal sensation. So starting with heart rate, fetal heart rate is a very important factor when it comes to labor and delivery because, number one, it helps with oxygenation of fetus. But number two, it can also be an assessment tool, or is an assessment tool for the labor nurse. So we can look at a fetal heart rate on the monitor and we can determine how well this baby is responding to the labor and delivery process. One important thing to note is that in fetal heart rate, there is a baseline that is where the fetal heart rate is most of the time. The fetal heart rate has also something called accelerations, which is an increase from the baseline, and then they have something called decelerations, which are a decrease from the baseline. Specifically, when we're looking at fetal responses to the actual labor process, one thing that is pretty normal to find is an early deceleration in the fetal heart rate. And this basically happens due to contractions. So early decelerations happen along with a contraction, and it occurs because of the way that the baby's head becomes compressed as it is moving down through the birth canal and pushing against the cervix. It's a normal finding, this type of deceleration, and it's harmless in a baby that is normal and has normal oxygenation stores. So early decelerations are okay, and they just mean that there is some head compression occurring in the baby. From an acid-base status, what we tend to see in the fetus is a slow decrease in serum pH from the start of labor until labor is over with. However, during the second stage of labor, or the pushing stage, there's a more rapid decrease in that pH. And as the base deficit increases, fetal oxygen saturation can drop by as much as 10%. So why does this happen? So this is where your critical thinking comes into play. So during labor and delivery, the uterus is contracting, and the contractions from the uterus interrupt blood flow and oxygenation exchange between the placenta and the baby. So for a typical normal healthy fetus, they typically have enough oxygen stores, enough reserve to make it through those contractions and be okay to make it all the way through the labor and delivery process. But as we've got these contractions happening and we have that interruption in blood flow and oxygenation, what happens is the carbon dioxide level, or the base, starts to increase in the baby. So slowly it starts to creep up as contractions begin, and as they start to get stronger and stronger throughout the first stage of labor, all those 3 phases. And as contractions get stronger, closer together, and more frequent, particularly during transition and pushing, which is the second stage, We see a more frequent interruption between that oxygenation process, and so the carbon dioxide builds up quicker, and that's why you see a more rapid decrease in the pH during the second stage. And then we have to talk about hemodynamic changes that occur as well in the fetus. So, fetal blood pressure actually acts as a protective mechanism during periods where there are no oxygenation caused by the uterus that is contracting. Um, so that is how they keep that's how they keep from becoming hypoxic during those contraction periods. Their blood pressure helps protect them. So in a normal fetus, it's perfectly fine, but in a fetus where there might be some alterations is where you're going to start to see complications related to contractions and progress and toleration of labor, which is why it's important to be able to test moms that we're suspicious of. So think back to the contraction stress test. Also, fetal and placental reserves are usually sufficient to keep the baby safe from an oxygenation standpoint during these anoxic periods. But if those reserves are cut short for whatever reason, or there isn't enough, the baby's in distress, the uterus is not relaxing, and there's not enough resting tone between contractions, that reserve becomes depleted, and then you start seeing signs of difficulty in the baby. Fetal sensation starts around 37 to 38 weeks, and at that point, the baby is able to actually experience what light is like, sound, and touch. And a full-term baby can hear music, they can hear their mom's voice. Um, and again, they're sensitive to light even in utero. The uterus becomes so thin at this point in pregnancy that it actually does let in some light from the outside. And they're aware of the pressure sensations that happen during labor. So let's think back to the early decelerations. If we know that early decelerations are caused because of head compression, the baby can actually sense some of that pressure occurring as they move through the birth canal. And so it creates sort of a vagal response in the baby, which makes the heart rate sort of decrease a little with the contraction. Okay, so electronic fetal monitoring is a really important part of the assessment of a fetus during labor and delivery. It produces a continuous tracing of the fetal heart rate as long as the monitors are left on and they're in the correct position. And nurses who are trained to interpret the fetal heart rate can intervene because it can give indications of what the fetal status is in utero. Is the baby doing really well in regards to labor and contractions, or is the baby having some difficulty that we need to intervene? There are different methods that we can use to do electronic fetal monitoring. We can do it through ultrasound. We can use telemetry systems, which allow the mom to get up and walk around the labor unit. So just like a telemetry heart monitor, there are telemetry electronic fetal monitors. And then we also have internal monitors that can be placed inside of the mother, that are placed inside of the mother onto a fetal part that will give us a fetal heart rate tracing. Probably what you are most familiar with are the ultrasound methods, and that is just the little round piece that fits on the mom's stomach to trace that heart rate, and it does it through ultrasound technology. So we talk about baseline for the fetal heart rate. That's the most important piece you have to be able to interpret first. An average fetal heart rate is rounded to increments of 5 beats per minute when we're talking about baseline. And a normal fetal heart rate ranges somewhere from 110 beats to 160 beats per minute. A wandering baseline is a baseline that will fluctuate between 120 and 160 beats per minute, or actually 110 if we're looking at normal ranges. And a wandering baseline is important because it can be associated with neurologic impairment in the baby or a pre-terminal event, meaning a bad thing that might happen. Immediate intervention is needed whenever you recognize or interpret a wandering baseline in order to enhance fetal oxygenation, because what's happening is there's something that is impairing oxygenation status that's going to lead to a bad outcome if you don't intervene when you notice a wandering baseline. Fetal tachycardia is a sustained rate that is greater than or equal to 161 beats per minute. And then we also have a subcategory of fetal tachycardia called marked tachycardia, and that means a baseline that occurs at greater than or equal to 180 beats per minute. Fetal bradycardia, on the other hand, is a baseline that has a rate of less than 110 beats per minute during a greater than or equal to 10-minute period. So to be able to call a certain number your baseline, you have to have, you want to be looking at 10 minutes time frame. Just like adults, babies can also have arrhythmias and dysrhythmias, and that just means that there's a disturbance in the fetal heart rate pattern, and they can be related to structural abnormalities or some type of congenital heart disease or defect. But you can see those on fetal heart rate tracings sometimes. Variability is an extremely important telling assessment tool because it measures the interplay between the sympathetic and the parasympathetic nervous systems of the fetus, so kind of your fight and flight response. And reduced variability is the best predictor for determining if a baby is going to have some type of bad outcome. Absent variability, which means nothing, no variability, that does not seem to be congruent with some type of sleep cycle that the fetus is going through, or drug administration. So, for example, narcotics that you're giving the mom for pain, that can be a warning sign that the baby is headed for trouble. Accelerations, on the other hand, is a transient increase in the fetal heart rate, and it's normally because of fetal movement. So think back to the non-stress test that we've learned about. A lot of the times it accompanies uterine contractions. When the babies get squeezed by a contraction, they tend to move, and so you will also see an acceleration. And again, those are used as the basis for your non-stress test. Decelerations are periodic decreases that happen in the fetal heart rate, and they decrease from the baseline. We have 3 different types of decelerations. We have earlies, lates, and variables. And the onset of uterine contraction decelerations are considered early decels. Ones that are late are caused by uteroplacental insufficiency. So remember, the earlies happen with a uterine contraction and they're due to head compression. Lates are caused by uteroplacental insufficiency and they come late after the contraction. Variables are caused by umbilical cord compression. So somewhere in the uterus, the umbilical cord is being squeezed during a contraction, and you see an abrupt drop in the or decrease in the heart rate. That's called a variable. These are all periodic changes, and when you're thinking about fetal heart rate and you're interpreting those readings, periodic changes are changes that happen with a contraction. A sinusoidal pattern is sort of an undulating pattern, which means kind of just up and down, but there's no variability with that pattern, and that's a bad indication. Decelerations are also classified based on the rate at which the fetal heart rate leaves the baseline or decreases from the baseline. So it can be very abrupt, which occurs in less than 30 seconds. In that case, it's typically a variable. It descends very abruptly from the baseline. Gradual ones happen in greater than or equal to 30 seconds. Episodic decelerations occur not in line with the uterine contraction. So episodic decels do not depend on whether or not you have a uterine contraction. However, periodic ones happen with contractions. Prolonged decelerations leave the baseline for a long period of time, somewhere between 2 and 10 minutes. And we're going to see examples of all of these. I have sort of taken the liberty of making some basic key term definitions to help you better understand these terms. So baseline is just your average fetal heart rate over a 10-minute period, and it's rounded to increments of 5. 110 to 160 is what we consider normal. Bradycardia is anything, is a type of baseline that is less than 110 beats per minute, and it has to last for at least 10 minutes or more. Tachycardia, on the other hand, is anything over 160 beats per minute, and it also has to last for 10 minutes or longer. An acceleration is an increase from the baseline, and we can have two different types. We can have 15 by 15s or 10 by 10s, and that means that the increase has left the baseline and climbed at least 15 beats, and that entire acceleration has lasted at least 15 seconds or longer. So your heart rate has climbed from the baseline at least 15 beats or more, and it's lasted for at least 15 seconds before it comes back to baseline. And 10 by 10 is the same thing, except it's just 10 beats above the baseline and 10 seconds. The significance between the two is that a baby at term should be exhibiting 15 by 15 accelerations, but a preterm baby is okay if they only exhibit 10 by 10s, because remember, we are talking about some neurological aspects that go along with this heart rate. So a preterm baby is not as developed as a term baby. So that's why a 10 by 10 is okay for preterm, but a 15 by 15 is what we want to see for a full term. A deceleration is a decrease from the baseline, and we can have, again, early, lates, variables, and prolonged. So earlies happen with a contraction. Late decelerations happen after the contraction. Variables are related to cord compression, and they are an abrupt drop from the baseline, and prolonged decelerations occur anywhere from 2 to 10 minutes after they drop from the baseline. So I'm going to see if my little marker here will work, and I'm going to write you out a little mnemonic. So one way that you can remember decelerations is by VIL. It's really difficult to write with a mouse. VIL chop. I don't eat veal, so I have no idea what a veal chop tastes like, but this can help you remember decelerations. So V stands for variable, and it is variables happen because of, oh my gosh, handwriting's terrible, cord compression. Okay, so the cord is being squeezed. E stands for early decels, and they are related to head compression. Oh gosh, y'all, handwriting is terrible. Okay, so earlies are related to head compression. A stands for accelerations. Okay, so these accelerations are okay, they're good. And L stands for late. Okay, so late decels, and that is related to placental insufficiency. So lates are bad. All right. Variability are fluctuations from the fetal heart rate that happen either above or below the baseline. And there have to be at least 2 cycles or more a minute, and we can consider variability in terms of being absent, so no fluctuations at all, minimal, there's a little fluctuation, I think it's less than 5 beats above or below the baseline, and then moderate variability is anywhere from 5 to 25 beats above or below the baseline, and then marked is anywhere above 25 beats above or below the baseline. So how do we evaluate fetal heart rate tracings? Well, we begin by looking at the uterine contraction pattern. We determine if there's enough resting tone. Is the uterus getting enough rest so things can be reperfused? And we assess the contraction frequency. So how often are they coming? The duration, how long are they lasting? And the intensity, how intense are they? How strong are they? And we evaluate the fetal heart rate by determining what the baseline is, what the variability is, whether or not there's a sinusoidal pattern, and whether or not periodic changes exist. We consider fetal heart rate tracings to be either reassuring, meaning that things are going well and the baby tolerates labor, or non-reassuring, meaning that there is some trouble that is happening that we need to intervene for. So the baby is not tolerating things. A reassuring pattern has a baseline within normal range. Variability is at a moderate point, and periodic patterns consist of accelerations with the baby's movement, and you may see early decelerations if the baby is moving into the birth canal, and that is okay. On the other hand, non-reassuring patterns have severe variable decelerations. So severe meaning they drop from the baseline quickly, but far from the baseline. They may last for longer periods of time, but quick variable decelerations can be okay. It can just mean that the baby is lying on its cord in one way or another, and a simple position change might correct that. So a non-reassuring pattern means we've got some severe variables happening. Late decelerations of any type, small, big, long, short, those are non-reassuring because it's telling us that the baby is not getting enough oxygen and doesn't have enough oxygen reserve to make it through that contraction. Absence of variability is also a bad sign because that means neurologically something is not right with the fetus, and they cannot really aren't doing a good job sustaining through labor. Prolonged decelerations are also bad. Remember, these are the ones that last anywhere from 2 to 10 minutes. Imagine trying to hold your breath for 2 to 10 minutes. That's kind of what a prolonged deceleration would be like for a fetus. Severe bradycardia is not good. Also non-reassuring. And these type patterns require continuous monitoring at the bedside. We don't let these moms get up and walk around. We have the monitors on her, and we are looking at that pattern and interpreting every little piece of it and trying to intervene. So let's look at some patterns now. So baseline's got to have at least 2 minutes of uninterrupted fetal heart rate strip to determine a number for the baseline. Okay, so each of dark red lines right here are a minute. And if you look closely, there are 6 boxes in between these 2 dark red lines. So each of those boxes stand for 10 seconds time. So we're moving this way for time. Okay, so 10, 20, 30, 40, 50, 60 equals a minute between here and here. So when I say you've got to have 2 minutes of uninterrupted fetal heart rate strip to determine the baseline, that means you got to have at least 2 minutes where you can see that the heart rate is uninterrupted, meaning no accelerations and no real decelerations or variables. Okay, so we've got a good 2 minutes right here. Okay, 1, 2. Our baseline is around about there, right? So if we're looking all the way down the strip, and even if we're just looking at these couple of minutes, our baseline moving up this way is heart rate. Okay, so that's what these numbers stand for. So if we are looking at this line of 2 minutes that's uninterrupted, no accels or decels, our baseline is going to be around 140. Okay, so this is 150, and each of going up, we go up by tens on this particular strip. So we've got 120, there's 130, 140, and 150. So most of the time, from a baseline standpoint, this heart rate is at 140. And remember, we round to increments of 5. So normal is 110 to 160. This one is 140. So this one is good. We're okay. And this is an example of a reassuring pattern because we have a normal baseline. We have good variability, which means this part of the strip, okay? Our variability is moderate in this one because it's increasing and decreasing in little sections, at least 5 beats above or below the baseline. And we also have 15 by 15 accelerations. This whole thing right here is an acceleration. This whole thing is an acceleration. This is an acceleration, and then we're back to baseline at 140. And it goes up at least 15 beats from the baseline, because up here we're almost at 180, right? So 140 to 180 is at least 15 beats above the baseline, and it lasts for at least 15 seconds. Remember, this way is time. Okay, so if time is measured by 10 seconds in each of these little blocks, this acceleration starts here and is over around there. So it's lasted at least a minute or longer. So that's how we say it's a reassuring pattern. Bradycardia, on the other hand, is the fetal heart rate that's less than 110 for a period of 10 minutes or greater. Now, how many minutes do we have here? Let's count them. That's 1 minute, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so we've got at least 12 minutes of strip to look at. And here is 110 right here. Here is 160. So anything in this section of the strip would be a normal baseline. Well, that's not where ours is. Ours is way down here at 60. That looks to be about 70. Okay, so around 70 beats per minute is what our baseline is for this fetal heart rate strip. And it stays there for at least 10 minutes or longer. So we can call that fetal bradycardia. This can happen with or without A cells, D cells, or variables. So you can call somebody bradycardic even if they have some accelerations or some decelerations or some variables, or none of any. It's associated with a vagal response from the baby. Sometimes it has to do with cardiac conduction issues, trisomy 18, so congenital anomalies and chromosomal abnormalities, and sometimes it has to do with maternal connective tissue disease. We manage bradycardia with intrauterine resuscitation if we need to, so fluid bolus, turning mom on her left side. We may have to give oxygen. We may have to give an IV bolus. So all of those different types of intrauterine resuscitation measures would be appropriate for a baby who had some fetal bradycardia. Tachycardia, on the other hand, from a fetal standpoint, is a baseline fetal heart rate that's greater than 160. Here is 160 on our strip, and it has to last for at least 10 minutes or longer. Now, we may not have 10 minutes of strip here, and this one is difficult to see the green lines, but there's 1 minute, there's 2, that's 3, and actually it's even difficult for me to see. This strip looks like it's been shrunk, sort of. So these dark green lines are your 1 minute intervals. You cannot see the 10-second lines between each minute. So we have definitely 10 minutes or longer. So we can say that this baby is tachycardic because the heart rate stays up there for longer than 10 minutes. And we're looking at, if you draw a line down the area where the fetal heart rate is at, the majority of the time, okay, it is somewhere between 200 and up here. And this fetal heart rate strip is counting by fives. This is 160, 165, 170, 175, 180. So if we know that this is 200, sorry, my little cursor is hard to control. If this is the 200 beats per minute line, and this is the 205 beat per minute line, we're only counting by fives. We're rounding to the nearest five, so we really could say that this fetal heart rate is 200 or 205 because it's kind of between both. This can happen with or without accelerations, decelerations, or variables, just like bradycardia. It's associated with tachycardia, particularly, is associated with early gestation babies or premature infants. Infection, if the mom has an infection that's moved to the baby. Babies who have fetal anemia, so maybe you have some type of RH or alloimmunization issue, and the baby has got some type of anemia due to that. It can also occur because of cardiac arrhythmias in the baby and fetal hypoxia. And we manage this again with intrauterine resuscitation. So same kind of activities we talked about in the last slide, fluid boluses, position changes, oxygenation for mom. And I'm going to give you a quick little interpretation of this entire fetal heart rate strip to get you sort of critically thinking about what is actually happening to this baby without me ever seeing this patient or being able to assess her in person. I can tell you if I'm only just looking at the strip and don't have a history of the mom, I could interpret that what is probably happening is that contractions down here are too close together. Okay, I'm just trying to draw over these so you can see contractions. All right, we've talked a lot about resting tone and how important resting tone is for reoxygenation of the baby. This uterus is not getting much resting tone. So we've got a very small amount of resting tone there, almost no resting tone there, just maybe 20 seconds. Not very much resting tone there. There's not even hardly a minute of resting tone between most of these contractions. So there is some uteroplacental insufficiency that's happening. This is also called tachysystole, when you have too many contractions happening and they're happening too close together. That's called tachysystole. So this patient is tachysystole. There's not much resting tone here, which means that the fetus is not getting enough oxygenation and is becoming hypoxic. So the heart rate has moved from what is a normal baseline between here and here and has become tachycardic because things are becoming a hypoxic environment for this baby. And so that's just a quick little interpretation of how fetal heart rate strips can work for a labor nurse to show her what is happening in utero to a baby so she can intervene. And of course, I did that without knowing any history on this patient at all. But that's how an interpretation works for a labor nurse. Okay, so accelerations are abrupt increases in the fetal heart rate of at least 15 beats from the baseline. They last at least 15 seconds, but less than 2 minutes. And again, 15 by 15s are what we like to see for term babies, but 10 by 10s can also be used as normal if the babies are 32 weeks or less. And that just has to do with the development of their neurological system. Associated with spontaneous fetal activity, so remember your NST. They can also be associated with stimulation and uterine contractions. And these are a favorable response, right, for our baby. These are good. We want to see accelerations in the heart rate. So you can see they've drawn your baseline here, and we don't have any numbers, so we don't know what it is. But a lot of places, the charting systems look like this, and there's a blue strip down the normal zone for baseline. So just because of my experience, I know this is a normal baseline due to the way the strip is set up. But the baseline is within the normal zone, and here is an acceleration. So the end of the acceleration, I drew it a little farther out, but the end of this acceleration is here because that's where the baby's heart rate goes back to baseline. And the beginning of the acceleration starts here from baseline. That's where it starts to climb and where it reaches back down to normal. So this is the peak of that. So you know that it's climbed at least 15 beats above the baseline, and it's lasted for at least 15 seconds, which tells you it's an acceleration that is a 15 by 15. Early decelerations are symmetrical. They happen gradually with the contraction. By the time the contraction is over with an early deceleration, the fetal heart rate will have climbed back to baseline. Early decelerations mirror the contraction. Again, they're caused by head compression, and we just monitor these closely, but these are normal responses to labor. So here's your contraction. And if you notice, the heart rate starts to go down and is back at baseline by the time the contraction is over. Okay, so it starts to gradually decrease here, and then it's back to baseline by the end of the contraction time. So they mirror the contraction. So let's look at this one. If I draw a line as straight up as possible with this mouse, and as straight up as possible on that side, here's the contraction. Now the contraction's back to resting tone, and the fetal heart rate decreases and increases back to baseline by the time the contraction's over. So that's an early deceleration, and it is okay. A late deceleration, on the other hand, is a symmetrical, gradual decrease in the fetal heart rate, and it returns to baseline, but it doesn't happen until after the contraction. Okay, so they're always associated with a contraction. So here's your contraction, the beginning of the peak, and where it ends. Okay, a late deceleration, if you draw a line from the peak of your contraction all the way through your fetal heart rate strip, a late deceleration is going to occur after the contraction. So you can see how this one, unlike the early one, does not line up with the contraction at all. It happens afterwards. It's associated again with uteroplacental insufficiency, and we manage it with intrauterine resuscitation. These are bad. We don't like lates. Variables, on the other hand, are a decrease that is abrupt. They have to be more than 15 beats or greater, and they last for 15 seconds or longer, but again, less than 2 minutes. Onset to nadir, which means the bottom portion of the deceleration, has to be less than 30 seconds from the baseline. So it takes less than 30 seconds for it to go from here to here. You can remember variables because they look like V's. So you can see how this one looks like a V. Sometimes they'll look like W's, but most of the time it's just like a little V. They are associated with cord compression. So what's happening in this picture, this is the interpretation. There is a contraction that is squeezing the baby, and somewhere in that uterus there is a cord, an umbilical cord, that is trapped between the head and the pelvis. It's trapped between the uterine wall and a fetal part. And every time this contraction climbs and hits peak, that cord gets squeezed. And as the cord is squeezed, oxygenation is cut off and the fetal heart rate decreases. But at the time that the contraction is over, there is a quick increase back to baseline. We manage these, again, with intrauterine resuscitation. Variables that are occurring because of contractions like this could be related to positioning. So turning the mom from one side to the other side or getting her off of her back can really help sometimes with the variables. Variability are those fluctuations in the heart rate, either up or down, that are irregular, and they are associated with the central nervous system function. Absent variability means you can't detect any change either up or down from the baseline. Those are non-reassuring, and that means there is possible compromise in your baby. Minimal variability means less than 5 beats per minute up above or below the baseline. That's typically non-reassuring, and that means there is also a possible fetal compromise. What we want to see is moderate. Moderate is the key. That is reassuring. So we've got a fluctuation in the fetal heart rate that is either 6 to 25 beats above or below the baseline. Marked means it's greater than 25 beats above or below the baseline. So here is an example. This would be considered absent variability. You cannot detect any variation around the baseline. You see a little teeny dip there, a little teeny tiny one there, a little teeny tiny one there, but for the most part, this fetal heart rate is a straight line. That means there's no variability. That's a bad sign. This one has minimal variability. So our baseline is around here, and my little marker here is kind of thick. But if you look at that, the fetal heart rate climbs a little above and below the baseline, which tells you there's some minimal variability. It's less than 5 beats from where I drew my line above or below. So it's kind of difficult to see, but not as bad as this one. Moderate variability, on the other hand, means that we have either 6 to 25 beat variation above or below the baseline. So they've, it's hard to see in the slide, but they've given you a little dotted line where the baseline is. So this baseline is kind of right there. Again, it's hard for me to hold this thing steady. So you've got that's some variability. All this above that baseline is variability. That's variability. And where you see all these squigglies, that is considered moderate variability because we're looking at 6 to 25 beats above or below where your baseline is most of the time. This one, on the other hand, is marked variability. And if you don't have the rest of this strip, it's very difficult to even know where the baseline is for this particular strip. But you can see the huge undulations in this fetal heart rate. That is greater than 25 beats above or below the baseline. So that's considered marked. Several years ago, all of the research showed that we needed a better way to classify fetal heart rate interpretations. So the powers that be came out with this 3-tiered fetal heart rate interpretation system. And we lumped things into categories based on interpretations. And this is a very easy way to communicate with your healthcare provider, your doctor or your nurse practitioner or your midwife who's taking care of the patient. If you're the nurse at the bedside and you need to call and give them a report, it is much quicker to say, hey, I have patient so-and-so in room 315 and she has a category 3 heart rate tracing. I need you to come evaluate now. That is a much quicker report than having to call and say, hey, I have so-and-so in room 315 and she is having contractions that last such and such, and the fetal heart rate is 160 baseline, and we're having some late decelerations with a few of the contractions. I'm not seeing any variability. So it's much quicker to call and say, hey, fetal heart rate's a category 3, I need you to come. And your person knows what that means. So they're just ways to interpret fetal heart rate tracings, and they're categorized into this 3-tiered system. A category 1 is normal, and that means it's strongly predictive that the baby has a normal acid-base status, and we don't have to have any type of action. A category 2 is an intermediate tracing, and this is what typically most people will be in labor. It's not predictive of an abnormal acid-base status, but it still requires surveillance and reevaluation by the care provider. A category 3, on the other hand, is abnormal. That means that there is going to be some type of acid-base status that is abnormal, and it requires prompt evaluation and more often than not, intervention. It's very important to understand this system, and people get training and they actually go to classes to be certified to do this if you work on a labor floor, and we use it so we can provide information about the patient to the provider so we can get orders quick and we cannot interrupt care in regards to time. So here is how we utilize these categories. A category 1 tracing includes all of the following things. It has to have a normal baseline. The variability has to be moderate, and you can have no late or variable decelerations. It's okay if there are some early decels, and accelerations can be either present or absent. So basically, to say that your patient has a category 1 fetal heart rate tracing, you just have to have a normal baseline with moderate variability, and you might have some early decels and you might have some acels. A category 2, on the other hand, means that you are going to have a baseline rate that can be either bradycardia not accompanied by absent baseline variability, or it could be tachycardia. Your variability has to be a minimal. An absent baseline variability cannot be accompanied with recurrent decelerations, or you can have marked baseline variability. Accelerations can be either absent um, when you're trying to actually induce them after fetal stimulation, um, or they can be present. And you have either periodic or episodic decelerations. So accompanied by or unaccompanied by a contraction is what periodic and episodic mean. Um, so there again, recurrent variable decelerations that are accompanied by minimal or moderate baseline variability. You can have prolonged decelerations that are greater than or equal to 2 minutes, but less than 10. Reoccurrent late decels that have a moderate baseline variability. Or you can have variable decelerations that have other characteristics that we really didn't talk about. So that's a lot. That's a mouthful, and I do not expect you guys to know all of that for testing purposes. Um, the category 2 is kind of the catch-all. Anything that's not a category 1 or not a category 3 falls into the category 2. But I will not be asking you any of this on a test. Category 3, on the other hand, you can remember that category 3 is bad. So category 1 is good, category 3 is bad. And category 3 is accompanied with absent baseline variability, which we've said is bad already. And then you have either recurrent late decels, recurrent variable decels, bradycardia, or a sinusoidal pattern. So all of those things are bad. So anything that's not here or not here falls here. So that's why there's so much language under the category 2. And there's even been some talk about actually making the fetal heart rate interpretation system a 5-tiered system, because the category 2 tracing encompasses so many different combinations of monitoring possibilities, that if you say you have a category 2, it could be okay, but it also could be bad. I've included you some additional resources for interpreting fetal heart rate patterns here. So you can click on these links and go there. I know this is a very difficult subject to understand if you haven't had the training for that. But what I want you guys to really understand is that this is a huge assessment piece of how we take care of a laboring mom and her fetus. This is how we see the patient we can't see. So it's important to be able to understand what you are looking at and interpret those different characteristics between contractions and what's happening with the fetal heart rate to determine if you need to intervene or if things are okay. Know your veal chop mnemonic, because that's very important, and that's something that you could be tested on that will even show up on NCLEX. And you need to know the different intrauterine resuscitation measures, and I have those listed here for you at the end of the slide. We would reposition ladies. We might even have to put people in a knee chest position. So turn them over on their belly, put them up on their knees and chest on the bed. So basically hiney in the air. That is a position that we might use if somebody was having some really hypoxic episodes from a fetal standpoint and we couldn't get things controlled. That would be sort of a last resort position. But side lying is what we do most of the time. We administer oxygen by a mask, and it happens at 10 liters when we are doing resuscitation measures for a mom. And that is because a little nasal cannula is not going to deliver enough oxygen to make it to the fetus. And that is who we are trying to get the oxygen to. Most of the time, the mom's oxygen status is okay. She might have an oxygen saturation of 100%, and we still put her on a mask at 10 liters because we're trying to get that extra oxygen to the fetus. An IV bolus is something we do. If you have your patient on any kind of medications, they're on a Pitocin drip for induction, they are getting magnesium for preterm labor or for pregnancy-induced hypertension or preeclampsia, or they have an epidural, we turn them off, y'all. We turn it off. If there's anything running and your baby starts to look bad, you discontinue your meds. We might have to place a fetal scalp electrode, and that's just a little device that actually screws into the top of the baby's head. Yes, and it screws in there whenever the baby is inside the mom. Nurses are able to put these on if they're trained to do so. And that helps to trace the baby's heart rate at a much more precise level than having the monitor on the belly of the mom. Fetal scalp stimulation is something that we might use to stimulate the baby. So we would do a vaginal exam and kind of scratch the baby's head a little bit to see if we can get the baby to respond if there is some type of abnormality in the heart pattern. We wouldn't want to do that during a deceleration. Because if there is a deceleration and you stimulate the fetal scalp at the same time, it could cause them to have a vagal episode and cause the deceleration and the hypoxic episode to be worse. So we would use fetal scalp stimulation for things like maybe we haven't seen an acceleration in a while and we want to make sure everything's okay. So we do a little fetal scalp stim to see if we can get the baby to have an acceleration in the heart rate. Amnio infusions are as a resuscitation measure that we utilize. There's a device, a catheter that we can actually put into the uterus. Membranes have to be ruptured, so the maternal water has to be broken to do an amnio infusion because you actually have to slip a catheter inside of the uterus and then you hook it up to some IV fluids and you can actually wash out, you can add in fluid to sort of expand the fluid inside the uterus, and that would be helpful if you had somebody who was oligohydramnios and they're going through labor and they're having contractions and you're starting to see severe variable decels, which tells you there is some cord compression going on somewhere, and we might need to put a little more fluid in that uterus to expand things and prevent that cord compression. We might use amnio infusions for babies who have pooped inside inside the uterus. So they've had an episode of meconium, and that is causing some hypoxic events. We might want to wash some of that out. So we would start the amnio infusion, infuse fluids into the uterus. But if that's the case, you're always with an amnio infusion going to monitor what's going in, how much is going in, and how much is coming out. Because the risk with doing this is putting too much fluid into the uterus and actually causing a uterine rupture. So there are a lot of assessment things that go along with that from a nursing standpoint. We may have to go ahead and prepare these people for a C-section so that we're ready if we have to do it quickly. We might have to give them some ordered medications depending on what's going on. If they've got too many contractions and they're occurring too close together and the baby is showing some hypoxia, we might give them some terbutaline to stop those contractions. If their blood pressure is crazy high, we might have to give some magnesium. If their blood pressure drops due to an epidural placement, we might have to give some ephedrine. We would call the healthcare provider if we cannot utilize resuscitation measures that make an improvement, but we would always notify the healthcare provider once we have done these. Even if they worked, we would call and we would tell them as well. Um, if you have a fetus that is needing any type of resuscitation measures, communicating with the nursery staff is key, because they are the people who are going to be taking care of this fetus once it's born, or taking care of the baby once it's born. So they need to know what you're doing. They need to know what kind of meds this baby is on. They need to know what the fetal heart rate tracing looks like. They need to know what potential complications they might be facing once the baby is born. Any fetus that is showing hypoxic looking fetal heart rate tracings, or fetal heart rate tracings that are not a category 1, you're going to want to keep those people on a continuous monitor, so that we are looking at that fetal heart rate constantly. We're not letting these people get up and walk around. We're not allowing them to be off of the monitor. We want to continuously monitor what that baby looks like. And making sure we keep up with the mom's vital signs is important as well. Sometimes progressing through labor really fast or really slow can also contribute to whether or not the baby is tolerating things very well. So assessing labor progress is really important too. What's the sterile vaginal exam? How far is she dilated? How long has she been in labor? Has the baby descended into the pelvis appropriately? And then keeping the patient and the family informed of what is going on. All of that has to do with allowing the patient to feel empowered as much as possible um, when things are starting to get a little out of hand and she's not able to control the environment like she would hope to do. So making sure that you tell them what is going on and why you are doing the things you're doing to keep them feeling somewhat in control. If you have to flip a patient over into a knee chest position, but you don't tell them why, um, that's not a very good nursing thing to do. I mean, you have to be educating them and letting them know why we're doing the things we're doing. Okay, so call me, email me with any of your questions, and take a peek at those additional resources for interpreting fetal heart rate patterns. But again, I don't expect you guys to be experts in reading a fetal heart rate pattern. I do expect you to be able to recognize an early deceleration, a late deceleration, a variable. I expect that you are able to know what causes each of those, so the veal chop. And we'll practice some in class. Thanks for listening.